Omental infarction represents an uncommon yet potentially serious abdominal condition. It is characterized by the necrosis of a segment of the omentum due to an acute compromise of its blood supply. This ischemic event leads to localized tissue death within this vital abdominal structure. The mechanism of omental infarction involves the interruption of arterial flow or venous drainage to a specific portion of the omentum. This vascular compromise results in ischemia, followed by infarction if blood flow is not restored promptly. Understanding this pathophysiological process is fundamental to recognizing the condition. The omentum itself is a large, apron-like fold of peritoneum, rich in adipose tissue and blood vessels. It extends from the greater curvature of the stomach and the first part of the duodenum, draping over the intestines. Its anatomical position and composition are key to its physiological roles. Grasping the intricacies of omental infarction is crucial for all healthcare professionals. Timely and accurate diagnosis is paramount to prevent unnecessary interventions and ensure appropriate management. Effective treatment strategies rely on a comprehensive understanding of its presentation and progression. The omentum is characterized by its extensive vascular network, which supplies its substantial fatty tissue. This rich blood supply is essential for its metabolic and protective functions within the abdominal cavity. The vascularity also contributes to its vulnerability in certain conditions. Beyond its structural role, the omentum performs several vital functions. It plays a significant part in the body's immune response, acting as a first line of defense against abdominal infections. Its lymphatic drainage system contributes to immune surveillance and inflammatory modulation. Furthermore, the omentum serves a crucial protective role for abdominal organs. It can migrate to areas of inflammation or injury, walling off infections and preventing their spread. This protective capacity is often referred to as the abdominal policeman of function. Despite its protective attributes, the omentum possesses inherent vulnerabilities. Its high mobility within the peritoneal cavity makes it susceptible to torsion or kinking. This anatomical characteristic is a primary predisposing factor for infarction. The potential for twisting or kinking of the omentum's pedicle can lead to acute vascular compromise. Such mechanical stress on its blood vessels can occlude arterial inflow or venous outflow. This disruption is the direct cause of ischemic injury. When the blood supply is compromised, the affected segment of the omentum undergoes infarction. The degree of ischemia and the duration of vascular occlusion determine the extent of tissue necrosis. This process underscores the importance of prompt diagnosis. The etiology of omental infarction is often idiopathic, meaning a clear cause cannot be identified in many cases. This makes diagnosis challenging, as there may be no obvious precipitating event. Clinical suspicion is therefore critical. However, several identified factors are associated with an increased risk of omental infarction. Obesity is a prominent risk factor, as increased intra-abdominal fat can predispose the omentum to torsion. The sheer volume of adipose tissue can alter its normal anatomical positioning. Trauma to the abdomen, even minor, can also contribute to omental infarction. Direct impact or sudden movements may cause the omentum to twist or become entrapped. This mechanical stress can initiate the ischemic cascade. Previous abdominal surgeries are another significant predisposing factor. Adhesions formed postoperatively can tether the omentum, making it more prone to torsion or kinking. Surgical manipulation itself can also induce vascular injury. Conditions that increase blood clotting, such as hypercoagulable states, can also contribute to omental infarction. Thrombotic events within the omental vasculature can directly occlude blood flow. These systemic conditions warrant careful consideration. Omental infarction may also be linked to underlying vascular diseases. Conditions like vasculitis or atherosclerosis can compromise the integrity and patency of omental vessels. This systemic vulnerability can manifest as localized infarction. The clinical presentation of omental infarction can be highly deceptive. Its symptoms frequently mimic those of other acute abdominal conditions, making differential diagnosis challenging. This diagnostic ambiguity often leads to delays in definitive management. The primary symptom is typically sudden, localized abdominal pain. This pain is often sharp and constant, intensifying over time. Its acute onset is a key characteristic that prompts medical attention. The pain is most frequently localized to the right lower quadrant of the abdomen. This specific localization often leads to misdiagnosis, as it closely mimics the classic presentation of acute appendicitis. Distinguishing between these two conditions is crucial. Associated symptoms may include nausea and vomiting, though these are less consistently present than pain. Their occurrence can further complicate the diagnostic picture, as they are common in many acute abdominal pathologies. Abdominal tenderness is almost universally present upon physical examination. The tenderness is typically localized to the area of infarction, corresponding to the patient's reported pain. Guarding may also be observed in some cases. The variability in symptom severity depends significantly on the size and location of the infarcted omental segment. Larger infarctions or those in more sensitive areas may elicit more intense pain and systemic responses. Smaller lesions might present with milder, less specific symptoms. The diagnosis of omental infarction relies on a combination of thorough clinical evaluation and advanced imaging techniques. A high index of suspicion is essential, especially when faced with atypical abdominal pain. The diagnostic process aims to exclude more common conditions. Physical examination typically reveals localized abdominal tenderness. Palpation may elicit guarding, indicating peritoneal irritation. A palpable mass is occasionally present, corresponding to the infarcted omental segment. Imaging techniques are crucial for confirming the diagnosis and differentiating omental infarction from other acute abdominal conditions. They provide definitive evidence of the ischemic process and its anatomical location. Imaging is indispensable for accurate management. Computed tomography, or CT scans, are considered the gold standard for diagnosing omental infarction. CT offers superior spatial resolution and tissue characterization, allowing for precise identification of the affected area. It is the most reliable diagnostic modality. CT scans typically reveal characteristic findings, including a localized, fat-containing mass within the omentum. This mass often exhibits a swirling pattern of fat and soft tissue, indicative of torsion. The appearance is highly suggestive of infarction. The CT images will also show signs of inflammation surrounding the infarcted segment. This includes fat stranding and thickening of the adjacent peritoneum. These inflammatory changes reflect the body's response to necrotic tissue. Furthermore, CT can indicate potential signs of ischemia, such as lack of contrast enhancement within the affected omental segment. This finding confirms the vascular compromise and tissue non-viability. The absence of enhancement is a critical diagnostic clue. While less sensitive than CT, ultrasound can also be used as an initial imaging modality. It may reveal a hyperechoic, non-compressible mass within the omentum. Ultrasound is often more readily available and can be useful in the acute setting. However, ultrasound's lower sensitivity compared to CT means it may miss smaller or less obvious infarctions. Its diagnostic utility is limited by operator dependence and patient body habitus. Therefore, a negative ultrasound does not rule out the condition. The primary approach to treating omental infarction is conservative management. This non-surgical strategy is effective for the majority of cases, allowing the infarcted tissue to resolve spontaneously. It minimizes invasive procedures and associated risks. Conservative management typically involves pain management to alleviate the patient's discomfort. Non-steroidal anti-inflammatory drugs, or NSAIDs, are often effective in controlling the pain. Opioids may be used for more severe pain. Intravenous fluids may be administered to maintain hydration, especially if the patient experiences nausea or vomiting. Fluid resuscitation supports overall physiological stability during the acute phase. This supportive care is vital. Observation is a key component of conservative management. Patients are monitored for resolution of symptoms and signs of complications. Serial clinical assessments help track the progression of the condition and ensure improvement. Most cases of omental infarction resolve on their own within a few days to a week. The infarcted tissue undergoes a septic necrosis and is gradually reabsorbed by the body. This natural resolution avoids the need for surgical intervention. Surgical intervention becomes necessary in specific situations. These indications are carefully considered to ensure that surgery is performed only when truly warranted. Surgical management is reserved for complicated or uncertain cases. One indication for surgery is when the diagnosis remains uncertain despite imaging studies. If the clinical picture is ambiguous and other acute abdominal conditions cannot be definitively excluded, exploration may be required. This prevents misdiagnosis of more serious pathologies. The development of complications, such as peritonitis, is a clear indication for surgical intervention. Peritonitis signifies widespread inflammation of the peritoneum, often due to rupture or infection of the infarcted segment. This is a surgical emergency. A large infarction causing significant and persistent symptoms may also necessitate surgery. If conservative measures fail to alleviate severe pain or if the patient's condition deteriorates, surgical removal of the necrotic tissue is considered. This improves patient comfort and prevents further complications. The surgical procedure typically involves the resection of the infarcted omentum. This is often performed laparoscopic, which is a minimally invasive approach. Laparoscopic omentectomy allows for precise removal of the affected segment with reduced recovery time. The prognosis for omental infarction is generally good with appropriate management. The vast majority of patients recover fully without long-term sequelae. This favorable outcome underscores the importance of timely and accurate diagnosis. Key to a successful recovery is early diagnosis. Prompt identification of omental infarction prevents unnecessary diagnostic delays and inappropriate treatments. Early recognition guides the most effective management pathway. Prompt treatment, whether conservative or surgical, minimizes the risk of complications. Adherence to established management protocols ensures that the patient receives optimal care. This proactive approach safeguards patient well-being. Minimizing complications ensures a full and uneventful recovery. Avoiding peritonitis, abscess formation, or prolonged pain contributes to a better patient experience and outcome. The goal is always to achieve complete resolution. Understanding the causes, symptoms, and treatment of omental infarction empowers both patients and healthcare professionals. For patients, it provides clarity and reduces anxiety. For professionals, it enhances diagnostic acumen and therapeutic decision-making. Further research is ongoing to better understand the precise mechanisms underlying omental infarction. Investigating genetic predispositions, vascular anomalies, and inflammatory pathways may lead to new insights. This continuous inquiry aims to refine our knowledge. The development of more targeted diagnostic approaches and therapeutic strategies is also a focus of ongoing research. Improved imaging techniques and non-invasive treatments could further enhance patient care. The field continues to evolve for better outcomes.